miscarriages. And I was just asking for one son, but God gave us two, and my youngest is David. I could sense already that he's so special. When I learned that David had rheumatic heart disease, I could not believe that my son, whom I took care his whole life, would have that kind of sickness.
It was September 2014 when they found out that my heart was too large for my age. When I felt my first symptoms, I really felt excruciating pain and that I cannot even take another step. If I recall correctly, I even cried because of the pain. The doctor told us that there's a high chance that it is rheumatic heart disease.
When I've learned that David would have to undergo an open heart surgery operation, it was still so vivid in my mind. It was a Sunday, actually, but doctor said that we had to see her, and so we went to that hospital. And when those words came out from the mouth of that doctor, I was taken aback. I was looking at David, and he was like lying on the bed, and I said to my son, "Be strong, do not cry." And he said, "I am going to be very strong, Mommy." To have an early detection, or to at least detect in an early stage the heart condition of a child, it would really save a lot of children in the Philippines. And there will be less tears rolling from the faces of the mothers.
We are now screening children 5 to 15 years old so that we'll be able to detect earlier the presence of rheumatic fever and rheumatic heart disease so that we can give secondary prevention or the antibiotics. This handheld ultrasound machine consists of a transducer. This transducer captures and transmits ultrasound images. This is connected to a mobile device. It can be a smartphone or a tablet. It is very light, compact, and it's handheld, so it's easy to use, and you can transport it to different areas.
David was referred to me at 12 years of age. He was already in heart failure. The echo showed a very big heart. The only way to treat that is to replace the valve.
On the day itself, the nurse came in at around 5 a.m. and I said, "This is it. This is it." And so David was so quiet, and then he was wheeled towards the operating room, and I told him, "David, no crying." He said, "Mommy, no crying." But when the wheel started moving, I saw my son crying already. And I just prayed.
When I woke up in ICU, the first thing I wish is that I was the last person to experience all the things that I experienced, because it was too traumatic for my age. We don't deserve these things to happen again. These diseases can be preventable. They can find a better way to cure these diseases earlier.
The surgery of David could have been avoided if the disease was detected earlier when he was having initial signs, and we could have prevented the progression. starts from a strep infection because of the environmental factors of overcrowding. You can have one child having one strep infection to the next. If they are untreated, the strep infection will create an immune reaction. They do not feel anything. So now it's accepted that the echocardiogram is the best to indicate as a screening for children with heart disease. Why is rheumatic heart disease prevalent in the Philippines? It is multifactorial. We have environmental factors. There is limited access to healthcare, limited knowledge for the healthcare workers.
With this screening program, we hope that in the future, the burden of rheumatic fever and rheumatic heart disease will decrease in our country. The use of the handheld ultrasound machine will really help, especially in our remote areas.
I am a very proud mom. He's one of those who were given the chance to study in the College of Medicine. And he's now in his second year in proper medicine. That made our family so much proud of him.
I appreciate more life, treasure every moment that I'm with my family. I believe that if I become someone who has the knowledge, who has the ability to cure every disease of a pediatric patient, no kid can suffer the experiences that we had.
Hi, everybody. It's lovely to be here, and unlike the other moderators this morning, this is actually my first summit. So I'm really looking forward to the experience, and the program today and tomorrow and the sessions this morning have been fantastic. We've got a brilliant discussion lined up for us just before the lunch break, and what a great way to kick off the session today. Before we dive in, I just wanted to briefly acknowledge the incredible contributors that we saw in the film, of course, David and his family, and the healthcare professionals that work tirelessly to develop solutions to manage CVDs. This short documentary was actually produced as part of a series which was created for our global audiences across bbc.com, which is launching next week, in which we set out to, alongside a number of organizations from the global community of technology, healthcare, and development, to showcase ambitious initiatives and innovations to promote global health equity. As we all know, of course, in this room, CVDs are the leading cause of death globally, and 3/4 of CVD-related deaths happen in low-income countries. In this case, of course, we speak specifically about rheumatic heart disease, in this case, which affects 40 million individuals around the world, primarily children and adolescents. So, we raise the film raises awareness of the need of early diagnosis to improve prognosis for patients, but of course it also alludes to the greater challenges that remain globally in addressing and managing cardiovascular diseases and the systemic changes that are needed to accelerate change and drive positive impact for patients globally. So that's what we'll aim to do in our panel discussion today, to unpack some of the challenges that still persist, talk a little bit about some of the solutions and the interventions that are showing promise, and kind of discuss the value of large-scale collaboration between policy, healthcare, and civil society at large to drive and accelerate change. And I'm delighted to be joined on stage by a fantastic set of panelists who will be leading the discussion with me. So if you'd like to join me here, firstly, we've got Caroline Vitonga from Philips Foundation, the organization behind some of the work that we featured in the film in collaboration with the World Heart Federation. Welcome, Caroline. I'd also like to welcome Jumana Talla, the founder of the Brave Heart Fund in Lebanon. Welcome, Jumana. And Dr. Ratna Devi, who's the CEO of Dakshama Health and Education in India. We do think we might be joined by Dr. Mohammed Abdulaziz from Africa CDC in the course of the discussion, who's running a little late. But before then, we've got a fantastic all-female panel, which is absolutely exciting. So we'll just kick off. And Kristen, I'm sorry, I didn't see you before the session. Apologies. Kristen Akra from University of Bergen. My apologies. Welcome to the stage. Thank you, everyone, for joining. So, Caroline, I just wanted to start with you. It was brilliant to see the work that Philips Foundation has been doing, in this case, in collaboration with World Heart Federation. I'd love you to tell us a little bit about the broader mission of the organization and some of the work that you yourself have been overseeing in Siaya County in Kenya to bring solutions to communities there.
Thank you, Vlada, and also thank you for the opportunity to present the work of the Philips Foundation here. I think the film that you've just seen really epitomizes the work of the Philips Foundation. So our mission is to really improve access to care in underserved communities, working with non-governmental organizations such as the World Heart Federation, where we provide grants for innovative and for projects that have the promise of being sustainable and scalable. We also work with social entrepreneurs that have innovative solutions that really can improve access to care in underserved communities. So here we provide investments. So then going back to your question of the work that we're doing in Kenya, and that's work that we're also doing with NCD Alliance. So I see Dr. Karekezi, who's the CEO of NCD Alliance in Kenya here. So we're not an implementing organization, so we work through others to make sure that we're improving access to healthcare. In the project in Kenya, we are aiming to strengthen CVD care within primary healthcare, coming up with models of care that can be, sustainable, equipping these health facilities to be able to look at early screening for CVD risk, early screening for CVD itself, and being able to triage and refer to the higher levels of care, making sure that we have the right tooling to help the health workers to improve their symptom recognition, to be able to improve the diagnosis for CVD risk factors and the CVD themselves, and being able to refer, as well as providing guidelines, making sure that whatever guidelines that are there at the national level, they're being translated to the lowest level of care. These health workers have the job aids to help them with the management of these diseases. So that's the work that we are doing as the Philips Foundation in Kenya.
Fantastic. And when the work began, what were the kind of specific needs and challenges that the primary healthcare workers were facing in that context that you were hoping to address?
I think that's still the same problems that has been spoken on in the morning. So we have a general shortage of health workers. The health workers that are available, there's limited capacity to sort of, recognize CVD symptoms, the proper tooling to be able to manage, the availability of data systems where you have permanent records at these health facilities, such that if you're doing chronic management of patients, you're able to then go back to the health records, look at whether you're controlling these conditions, as well as issues to do even with essential medicines, so availability of even antihypertensive, diabetes medicines in these facilities, as well as effective referral systems such that these patients are able to properly navigate through the care systems to get to the proper care that they need. And I think also most of these challenges, one of the things they speak to is the importance of one integrating the interventions that we want to bring to primary healthcare with the already existing systems, making sure that we are properly integrating into the workflows within the facility so we are not adding on to more burden to these already overstretched health workers, as well as now making sure that the proper commodities, the medicines, so that when you do early diagnosis, then the patient has something else to be followed up on. So it's not diagnosis for the sake of diagnosis, but are we really bringing change to the health of these patients?
So whenever we talk about systemic change and comprehensive approaches, we always talk about the importance of the context and finding solutions that work for the local needs. And Jemana, when we were talking about your work, you speak really well about the very unique challenges that you see the healthcare community faces in Lebanon specifically. So I'd love you to talk us a little bit about the work of the fund more generally, but also what are those challenges that are specific to that region?
Yes, sure. Good morning. First, thank you for inviting me to be part of this panel. I represent Braveheart and Global Arch because Braveheart Lebanon is part of a global alliance for rheumatic heart disease and congenital heart disease. So we're bottoms up. We're a grassroots initiative started by families. I'm a parent. I'm a heart parent myself. And we basically we wanted to fund surgeries for children in need because we saw that most children have no access to high quality care in our country. And what started as a small grassroots initiative 20 years ago has grown to be a full registered NGO in the country. And so far we have funded 5,000 surgeries and 5,500 outpatient care, like diagnostic tests and so on. So about 10,000 cases served. Really thanks to the support of the community, peer-to-peer fundraising, and a huge partnerships, a network of partnerships that have allowed the fund to maintain 100% policy, which means 100% of every donation goes towards surgeries or medical care. And this, obviously, we have overheads, but they've been subsidized by the community who has provided in-kind services for a lot of things. And we've been able to sustain this for 20 years. So I think when the community sees that they are subsidizing a very efficient model, they will continue. So this is a way forward to sustainability. Lebanon is a very small country. So I know we were middle income, but we're lower middle income now because we've been hit by a huge economic crisis 3-4 years ago. All accounts have been wiped out. Government has defaulted completely. So we have a new reality, but constant adaptability is something we learned over 20 years as we faced wars, invasions, explosions, economic meltdown. But it taught us every year we have to come up with new solutions and new challenges, of course. So we did lose 2 years of surgeries at the bank, but we had to start again. That's for Braveheart. It is the first patient fund in a hospital, and that's, I think, a very interesting model, which was difficult in the beginning to convince the university hospital center where we actually deliver the services to embrace community-led initiatives, but they did. And now they're modeling several other funds modeled after Braveheart. And it is the biggest fund in the country to support heart surgeries for children. We do collaborate with the Ministry of Health because, of course, what Braveheart does is fill the gap, fill the financial gap. So we do have support from the state as Lebanese individuals, whether Social Security or from the Ministry of Health. But that really is about 40% of the surgery, and less than 5% of the population is covered, has insurance that would cover or self-pay all the rest needs financial support, and people couldn't access the surgeries unless there was this support. So Braveheart Fills the Gap becomes a sort of an insurance to the patients. We don't give just a specific amount. We don't say, here's 1,000, go do your surgery. We actually cover all the residual, hospitalization, everything that's needed. And so we were able to get up to about 350 surgeries a year funded by Braveheart or interventions. Now, of course, we've been slashed down to 200 and less for the same amount of money, because the government has practically disappeared on us. Government used to fund about $5,000 per surgery. They're down to 500. So we have to, it's a bigger gap now. But we could carry on.
You know, it's really interesting context, and it's useful to think about the different stakeholders that play a role in sort of that comprehensive approach that's needed to managing cardiovascular conditions. And Dr. Devi, I was thinking a little bit about the work that you do in India. Obviously, you're driven by patient education and advocacy, and that got me thinking about that question of, you know, the patient voice and how important that is in creating bottom-up demand and interest and pressure, and how does that then kind of impact changes that could be influenced. So tell us a little bit more about that work and the role that you see organizations.
Thank you, and thank you for inviting me to share these thoughts. And as you said, how important is the patient? So I'll start with nothing about us without us. If there is no patient, you will never learn what the patient wants or what you have provided is actually working for the patient or not. So it's extremely important that patient is part of the whole care journey, and that they are included in the conversation, whether it's deciding what is good for them or discussing with them what is not working for them or trying to give them an alternate solution. But that can only happen when you include the patient and treat them as an equal partner in the care journey. And usually our healthcare systems are so overburdened that physicians do not have the time to have that conversation. So we have to create other solutions where the patient is able to share that experience. And that's how we started this whole initiative, and especially through a personal experience where I nearly lost my father to a cardiac event within a multi-speciality hospital, because there were so many different departments working on him. He was operated for oncology and then underwent a cardiac event, and the pulmonologist, the cardiologist, and the oncosurgeon were not talking to each other because they were so busy looking at so many patients. And we as family and caregivers knew that something is not working because we saw our father restless. We saw that he was not responding. His hemoglobin level was continuously falling down, and we tried to reach out. But as I said, the oncologist felt that the surgery was complete and successful, so he didn't bother. And the cardiologist was not available because this patient was not on his list, until there was a cardiac arrest, and then everybody ran. And that's how we learned that, you know, it's, even though I am a trained physician and my sister is a trained physician, nobody listened to us. So I understood that the patient voice has to be empowered to a level where we are treated as equals. Even as trained people, when you are on the opposite side, within the hospital's doors, you become a caregiver or a patient. You're not treated as a professional because the healthcare system is built in such a way that it is very top-down. In medical schools, you're not taught to treat your patient as an equal. It's, you are the person who has the knowledge, and therefore you impart that knowledge through your physician skills, and you give the treatment that is appropriate. So that's how I started this organization. When I started, I had no clue what I would do, because as I said before, I wasn't taught how to train a patient. But I was fortunate to have been included into patient organizations worldwide, and I attended a few congresses where patient groups were very vocal. They knew exactly what they wanted to do, how they wanted the systems to change, and I said, I need this for my country, especially where healthcare is very complicated. We have an equal amount of public healthcare and private healthcare, and in the private healthcare, the patient has pretty much no voice. It's how much you pay that will decide what kind of care you will get. So we started this organization 12 years back, and we now have something called the Indian Alliance of Patient Groups, which is a cross-disease patient organizations representing all kinds of patient groups. So we are therapy agnostic or disease agnostic. Any patient group that requires support can come and join us. And what we try and do is to work across the spectrum. So for those that are just starting and are fledgling, we build their capacities to register themselves as an organization, understand what their advocacy agenda should be, and how to reach out to policymakers and regulators to make that voice heard, to very strong established patient groups who have already done some kind of capacity building, but have to move forward to maybe bring in new therapies into the country, so work with regulators, or change therapeutic protocols that exist within the country, work with the research organizations to bring new clinical trials. So across the spectrum, our work is, there in the context of the country. So we have become so successful that countries around us, around India, have started to reach out through patient voices, sometimes individual patients, sometimes caregivers of patients who are looking for solutions, trying to understand how to set up patient groups within their countries. And we try and help them because the health systems in every country is very different. The political systems and the funding mechanisms for healthcare is very different. So we try and understand and then try and set up patient groups for them as well. Now, in terms of patient voice, why is it important? Sometimes the way the patient journey is described by a clinician is very different from what the patient understands as their patient journey. So the physician would think, their journey would start once they visit a hospital. So the patient visits the hospital, there is a diagnosis, there is an investigation, a diagnosis, and then a treatment, and maybe some advice and follow-up. Maybe a critical incident in terms of a cardiac event, back to the hospital, again some treatment and advice, and this is how the journey goes in terms of the clinician's aspect. But look at the patient. When we do patient journeys, then the patient might start with, I had a fever, and then I had breathlessness, and I went and I got my blood pressure checked, and that's when I discovered I have high blood pressure. And then I went back, I did not take my medicines because I went to a marriage and I forgot. I had a stroke because I forgot my medicine, and I was admitted to the hospital. I was treated for stroke, but nobody told me anything about diabetes, which I had developed in the, in the intermittent duration. And so I was discovered with diabetes when I was admitted for stroke, and I was given treatment for that. So it's not a straight journey, the way the health system describes a patient journey. So we do a lot of work on describing patient journeys, on capturing patient journeys, and talking to physicians as well as healthcare providers and hospitals and policymakers to tell them, you have to understand the patient's perspective of what their journeys are to make the health system better. It's not going to work if you don't understand what the patient wants.
And it sounds like you're on a journey with lots of great impact being delivered and results being achieved, but it sounds like more could be done to integrate those patient voices into systems of care. Is that fair to say?
Yeah. So
Welcome, Dr. Abdulaziz. How are you? Great to see you.
We have come a long way from the day we joined. I mean, we were treated as activists who were demanding things that were not possible because of limited resources. But the more we had dialogues with policymakers, the more they understood the value of what we were bringing to the table. And we are now much more welcomed, and we are invited to almost all meetings that the government holds, especially where policymaking is concerned. Most documents are now open for public review before they are converted into policy documents. And let me just give you a small story. So we were working for getting a new medication for stroke included into our national formulary, and this particular medicine was 3 times the cost of the one that was originally included, and we were getting stonewalled. Nobody was willing to listen to us. So we have something called a medical parliamentarians forum. So these are all members of parliament who are also doctors. And we took 10 stroke patients to a medical parliamentarian forum meeting, and we shared stories. And after the stories were shared, like the one that we saw just now, slowly, one by one, the minister stood up and said, you know, I had a similar incident in the family where we couldn't get care on time, or my father lives in a remote area and we did not have a neurologist there, so he had to travel 400 miles to come to the nearest hospital. And once we had those people converted and belief, and the belief in them came that, you know, there is something that needs to be changed, things moved very fast. So I think patient stories and patient experiences add a lot of value. It's just that we have to find the audience to be able to share those in a scientific way, not just the emotional part of it, but also bring the data to support what you're demanding so that the policy change then becomes easier.
That's brilliant. And I do want to come back to the kind of the patient centricity and public health education campaigns as well. But I'm jumping around a little bit, but I was just reflecting on what Caroline was sharing about the kind of the start of the journey really in that diagnostic space and how we improve the rates of detection. And Kristen, I know the work that you do, of course, and the research that you lead at the University of Bergen focuses on some of the emerging biomarkers in cardiac space and how they can be enhanced and better used for to diagnose CVDs early and more efficiently. It'd be great to hear from you. Just give us a sense of kind of where that journey is. To what extent is that research being leveraged actively, and what more can be done to use it to enhance the quality of diagnostic processes?
Yes, thanks for inviting me. It's really a pleasure to be here. I am, as you said, a cardiac biomarker researcher placed in Bergen, but I also have a very large engagement through the International Federation of Clinical Chemistry, and we have a committee on clinical application of cardiac biomarker, and this is a worldwide organization, and our group have members from all around the globe. So this is a lot of my experience come also from this group. And I think just to get everybody on the same stage here, I would like to say something about the importance of diagnostic biomarkers to achieve this kind of equality and this kind of patient care that we need, and the availability of it everywhere in society. So blood tests accounts for approximately 70% of all clinical decisions. 70% of all clinical decisions are done based on a blood test, in part or fully, based on the blood test result. And cardiac biomarkers are special in this matter because we have cardiac troponins, which is a protein which is released when your heart is injured. And this blood test is actually included in the universal definition of myocardial infarction. So to have a diagnosis of myocardial infarction, or to have a high quality, a sensitive diagnosis of myocardial infarction, you need to be able to measure this blood test. And I remember very well when this was implemented in my country in 2000, because then we could see that then we would measure the old markers in parallel with troponins, and we could actually see that this patient, like 1 month ago, we would have sent this patient home and said, there is nothing wrong with your heart, go and do whatever you like, you're fine. And now, after measuring troponins, we would send that patient to cath lab and get them treated for myocardial infarction. And this, of course, very, very much affects the outcome of the patients. So, and it's the same for heart failure. There we measure neuritic peptides. It's included in the definition of some kinds of myocardial of heart failure. So it's absolutely crucial that patients around the globe can have access to these tests. And the IFSC is at work for you all the time, and we have a website where we try to highlight the different tests and which quality they have, because we know that there is a lot of low quality tests out there. So I think one of the things that are really, really important is that we can have, or governments needs to have a national diagnostic strategy how to implement these tests. Of course, the large laboratories, they are kind of the driving force in the diagnostics. They are the main, our main tool to get this through. But they require like a large infrastructure, very skilled, high competent personnel, and so on. And also, they cannot be available everywhere. So, and these are acute conditions, right? So sometimes, to increase the availability, we need point-of-care instruments. And now this is available. The technology is available, but it's not implemented. And this is not only in low, middle-income countries, it's also in high-income countries. So I think these are one of the major tasks that we need to work on, the availability, and then it's to increase the competence, because we know that even when these tests are available, they are not always used correct. And that severely affect how the patients are treated. And that also is a major threat to equality in healthcare, because if you don't interpret the test correct, you will not get the correct diagnosis, and then you will not get the correct treatment, right? So that is important, and this is for the acute conditions. These tests are also used for long-term risk prediction, and particularly in vulnerable groups like patients with diabetes, women with breast cancer who have cardiotoxic treatment. Then it's recommended to do regular testing of these cardiac biomarkers. So availability is the key here I think, to improve healthcare outcomes.
And what are your recommendations for immediate solutions, if there are any, to at least shift the needle ever so slightly in making this more accessible universally?
I think, I don't know if there is an immediate solution, but I think the planning is everything here. So we need to have national strategies, and that goes all around the globe, also in high-income countries, low-income countries. We need a national strategy how to implement the tests. And very recently, I have been traveling in Asia, for instance, and there is the diversity and the it's so the gaps are enormous, and the differences in the access to healthcare is enormous. But also in like high-income countries, like my country, Norway, we think everything is all set and we have so high quality of our healthcare, right? But then when you look into it, we can see that our chest pain patients, we actually investigate quite a large percentage of our chest pain patients without measuring cardiac biomarkers. And we know that this affects the outcome. And I hope the Norwegian healthcare minister is here, because we need to do something with this, right? And we don't even see it, because it's so embedded in the healthcare system. So we don't realize how this affects outcome of patients. So I think planning is everything. We need a strategy, how to make the technology available for everybody. And then we also need a strategy how to enforce the healthcare workers and how to teach them how to use it. And that goes into very simple recommendations. Like when we implemented high sensitivity in troponins in Norway, we made a one-page recommendations for laboratories and cardiologists, and says this is the way you're going to do it. And to my surprise, they actually did it. So simple recommendation, educational recommendations, but also we need large research fund for this, so that we can do implementation research. We can actually check in randomized controlled trials what is the most cost-efficient way to do these diagnostics. Where should we use point of care? When should we use it? How can we change to the benefit of patients? And then also, one of my really heartfelt tasks is, what about women, right? We know women have less access and less treatment, and how can we, how are we going to deal with that matter, right? So we need randomized controlled trials also on biomarkers to find out how they can best be used, and how we can improve the outcome of patients.
Thank you for sharing that. And Dr. Abdulaziz, actually, you join us at a good moment, because we've been discussing different perspectives from the panelists, from the importance of diagnostic solutions, the importance of innovative technologies, of course, the value of the patient voice. Of course, you have a broad perspective that you could share with us, and I'd be curious to hear about some of the focus areas for you at Africa CDC, and some of the spaces where you're kind of investing attention and energy. And I suppose in the context of, you know, the practicalities and the practical constraints and the local realities that exist across different regions, how do you determine what interventions and solutions could have an immediate effect, and which are the ones that you think can hold promise for longer term?
Thank you so much. And first, let me apologize for coming late. My flight came in very late, and then I got a lesson on how not to use the Geneva public transport. Yeah, and really, thank you. First, in Africa CDC, for those who don't know Africa CDC, where I work, is the public health institution for the continent of Africa, mandated to support the member states of the continent of Africa in prevention, detection, and management of public health events, including the disorders. One of the biggest challenge with an institution like that on the African continent is that people believe non-communicable diseases are not of public health importance. But the data have shown very clearly in Africa that we are now suffering from double hit, both infectious and non-communicable diseases, and quite an unusual, number, I think a significant number of deaths from non-communicable diseases are occurring on the continent of Africa. And partly one of the challenges we had when we first started pushing the continental institution to look at non-communicable diseases, to convince even the people at the top that they should invest in the prevention and control and treatment and management of non-communicable diseases. When we started that, it was difficult, but when COVID-19 came, it became very obvious, and this is what I want the audience to take away, is the same health system that is responding to endemic diseases like non-communicable diseases, diabetes, hypertension, HIV, TB, that will transform to become the workforce that we will use for pandemic and outbreak response. So if this workforce is not good, during national emergency, they will not be able to. So this became very clear. And that was when Africa CDC set up the division that I lead, that is working to put non-communicable diseases high up. And I can tell you, one of the first things we did was to push very hard for one of the strategic pillars of Africa CDC to be prevention and control of high burden diseases, including non-communicable diseases. And the second strategic plan of Africa CDC has that now. So this gives us the impetus to now learn. And to answer your question directly, one of the things we must do in the space of prevention and control of, and even the management and treatment of non-communicable diseases like cardiovascular disease is to learn how our colleagues in the infectious disease arena has been able to use some public health tools to make progress. And this is what we are trying to do in Africa CDC. In the areas of workforce, we want to see, we know in Africa, for non-communicable diseases that requires long-term treatment, most of our people still do out of pocket. Access is very limited because you need to go sometimes upward of 100 kilometers to get access to experts. So what we're trying to do is how do we improve the workforce that the countries have to be able to be responsive to some of the challenges we have in the management of non-communicable disease. Obviously, we cannot get a cardiologist in all the villages, but how do we link the cardiologist in some of the district hospitals with the community health workers so that when the patient goes back home, he's still able to access some basic level of care that can improve the outcome of that patient, including links using innovative methods to do that. And we are very glad in Africa CDC to see that we've seen example with PEM+. We were recently in Tanzania, where we saw how this model is working. And what we plan to do is to work with these stakeholders and scale up this kind of model to be able to work with different stakeholders and have an impact on the care of critical non-communicable diseases like cardiovascular, rheumatic heart disease, congestive cardiac failure, and the rest. That's one aspect. Another aspect is also to encourage our member states to invest more in domestic financing that can be able to take care of some of the things I heard you talking about, the diagnostics. I mean, we need to ensure that this gets to where it is needed. And as much as we are very grateful for the partners supporting, but again, we need to encourage our member states, the government, to increase funding to this area so that it will, the kind of impact we're looking for can be good. Finally, the good work that we're doing, one of the problems with non-communicable diseases is that we do not report to government the way infectious disease does. So the government don't see surveillance data. They don't see data on what they see is research data, some sentinel surveillance, but they don't see real-time data of how many of their people this thing is affected. And even when we have excellent work like the one they are doing in PEM+, how do we use their data to convince government that if they invest in that kind of clinic in a certain area, it comes with good returns in terms of the way the impact it has on the health system. Thank you.
Brilliant, thank you. That was fantastic insight. And one of the things that's coming through from all of these, from the conversation across the board, is this idea that there are lots of interdependencies between different parts of the health system and broader society. And it's clear that collaboration is the key word. Coordinated action is needed between healthcare systems, between patient organizations, government and civil society, development organizations. And that's actually a question for everybody. Please jump in with any ideas that you have. But how can collaboration be better leveraged? Can you share good examples of where that's working well from your experience? Where do you see opportunity to really advance this agenda?
Since I'm still holding the mic, let me just... I actually missed that excellent point. One of the things we are doing in Africa CDC is to restart the multisectoral task force, the continental task force on multisectoral action in the prevention and control of non-communicable diseases. Because in Africa, we know that the best way to go is to prevent. If it occurs, the cost to the health system is huge. So what we're doing in Africa CDC now is with the African Union, which is the organization that Africa CDC is under, has several departments that covers all the areas non-communicable diseases, has tentacles like the economic department, transportation department, housing, education, and information. All of those departments are housed within the African Union. And when we looked through, we realized that they are doing a lot and we were not seeing it. Like if you take cardiovascular prevention, for instance, they are doing programs encouraging governments to build walk passage and design in such a way that people can be able to move around instead of just jumping to cars. The education people are also doing something, but they are working in silos without coordination. So what we are doing now in Africa CDC, we'll set up that task force. We have the highest level buy-in in that task force, and we want to use working with member states to see how we can use multisectoral action to support what our member states are doing in terms of prevention and control of non-communicable diseases.
Breaking silos, great point.
Yes, two examples. First, working in laboratory medicine is very good because every medical specialty, they need to take a blood test, right? So it's very good for working transdisciplinary. And I think an example is this IFCC group on cardiac biomarkers, because we have included emergency physicians, cardiologists, and laboratorians, and we have also basic people working more in basic science, and we have also a lot of industry partners. My experience is that this kind of joint venture by industry and the medical community and research community actually is very, very rewarding, and it helps us very much to progress, because we are all working with the same goal, to increase the knowledge about use and interpretation of cardiac biomarkers. And we get a lot of feedback from industry, actually, because they get questions. All their customers, all the local laboratories, they will post questions to the industry about when they have a problem with a test, when they don't know how to respond to the test, and also about use of the test. Many times they will ask their industry, the provider of the test, before they ask other colleagues, right? So, and we get these questions back to us in the group, and then we understand what are actually the problems out there. And also, this group has corresponding members from all over the world, like from India, from South America, Africa, all over. So that actually helps us to get feedback from large parts of the healthcare systems, and to see many different aspects. And this is, I think this is quite unique, that you are able to engage so many medical disciplines in the same group, and also align with industry partners. And I think it should probably be an example for others, because it's really fruitful.
I think we're running out of time. 3 more minutes. And I know there's a couple of questions from the audience, and Ratna, I want to make sure you have a chance to for a closing remark.
I'll finish in 1 minute, so my other people have 2 minutes for them. So multisectoral collaboration is extremely important, and as Dr. Abdulaziz referred, especially within the government, because non-communicable diseases go beyond the realm of health. It's urban planning, it's environment, it is water and soil pollution. So many things are there. So multisectoral is important, but it's very hard to implement. There is a multisectoral roadmap for India, but then the ministries hardly ever meet to discuss that. And when they don't discuss, then financing becomes a problem, because who's going to take the onus of driving that multisectoral plan or roadmap? Having said that, there is an industry, CVD alliance, industry-led CVD alliance, which brings together people who are working within cardiovascular diseases. There's also a lot of patient groups, but again, patient groups work in silos. So the oncology groups, the heart failure groups, everyone is working in their own silos. They are not integrated together. The Global Heart Hub is a good place where all these agencies can come together, but the presence in Asia Pacific is very small. There aren't hardly any patient groups who are part of the Global Heart Hub, so probably that's something that needs work. Similarly, IVD industry and the manufacturers, the technology. We haven't talked about digital and the availability of apps, etc., that many patients use to diagnose themselves. And there's no work going on to discuss the integrity of these agencies. So somehow we should get all these players also for discussion across the table, so that the collaboration becomes good in reality.
Thank you. I think we are at time, I'm being told. So I think we might have to wrap here and draw a line, but a fascinating discussion. And please do grab up panelists after the session. Apologies, we didn't get around to question from the audience. But thank you all for the contributions, and enjoy the rest of the event. Thank you.